unless all these three things are there, I don't decide to operate the patient. Be very careful. I mean, this is not a surgical conference, but be very careful before any surgeon decides to operate on a partial rotator cuff tear. Sometimes the patients, if not given good rehab exercises after the surgery, ends up in a worse position than they are before the surgery. Correct? So if the patient did not have a very stiff shoulder before surgery and you ask a partial tear to undergo surgery, they might sometimes end up with a frozen shoulder, which will put them back by 2 years. So don't try and hurry up with a partial rotator cuff tear.
Okay.
Okay. Next, just a minute. Yeah. So what is the need for operative treatment? Because why am I speaking so much about partial rotator cuff? Because when it comes to a full thickness tear, there's not much of a discussion. Usually patients do have a lot of pain. They they ultimately do undergo a surgical treatment. But partial is where 80% of the patients or 90% of the patients are partial, and that is where the entire dilemma is. So when is the need for operating a partial tear? Where there is no relief post conservative, willingness to cooperate for exercise is very important, and the patient has progressed to full thickness cuff tear. Okay, so always remember these are the three things where you have to decide while operating a partial rotator cuff tear. Next, so what do we do for partial rotator cuff tear? We either do if the patient has 80% or 90% tear, then we sometimes take down the remaining 10% and repair it as a whole. Or in Australia, we used to have something called as biological augments, where we used to put a collagen patch on the top. But those things are not there in India. But in India, routine rotator cuff tear repair works as good. So along with that, we also take care of the acromial spur, we take care of the AC joint arthrosis, and we also take care of the biceps. So what do we do for the biceps in a partial tear or a full thickness tear? Every surgeon is different, but what I follow is I always try and do a fair bit of tenodesis. So what is tenodesis? Tenodesis is cutting the biceps from the glenoid and fixing it in the bicipital groove. What do you achieve by doing it? One is cosmesis. The patient does not have a Popeye deformity. The patient does not have a slippage of the biceps, and some sort of strength maintenance, though it is not exactly documented that tenodesis will improve strength, but at least what you can do is you can give the patient a cosmetically better arm. So even if you are taking care of the biceps, you are not giving the patient a Popeye deformity to live with. So I always release the intra-articular portion and refix it in the groove. So this is a very important treatment from the biceps perspective. Now, full thickness rotator cuff tear, arthroscopic is the best possible treatment. When do we not operate? We don't operate when the patient has absolutely no pain, which is very rare, but the patient is absolutely non-compliant to exercises, has arthritis in the shoulder, or is medically unfit. Otherwise, we usually undergo a rotator cuff repair surgery. So what do we do in a rotator cuff repair surgery? We use the following equipments. I have a very state-of-the-art ultra high definition system, which improves my vision. We use some anchors, which are basically small tools with which we help repair the muscles. We have specialized instruments for it. This is the typical patient presentation in the operation theater. The patient is lying lateral. This is the arm. Why lateral? Because it is safe for anesthesia, does not give a cerebral hypoxia, and the patient has a stable blood pressure. Or when a patient has hypotension, we are not worried that the patient will develop cerebral hypoxia. So I always insist that for rotator cuff repairs, the patient maintain a lateral position and not a beach chair. So we have different portals. We always undergo a subacromial decompression before we decide to operate the shoulder. And basically, this is a small presentation. I always show it. So have a look at this. It will just take 2 minutes of your time. This is what a typical rotator cuff tear looks like. You can see this is the U-shaped tear in the supraspinatus muscle. This is the supraspinatus belly. This is the subscapularis. Here you can see there are different portals or cannulas which are positioned so as to access the joint. As you can see, this U-shaped tear needs to be fixed back to the bone. So it has come off from the bone and it is basically causing a lot of pain and maybe symptoms. So here, this is how the tendon has elasticity in it and it is reducible. So this is very important with the rotator cuff tear. The reducibility is an important factor. So we should make sure that we are able to reduce and pull the muscle back to the bone. That is the whole aim of the treatment. So that is what we do. What we do is we put in small stitches. They are called as anchors. So we put these stitches inside the humeral head. Okay, we have special stitching needles. They are called as first pass needles. So they are basically a pass and grab, like what a cobbler would do. So basically we pass it through the muscle. So these are the stitches being passed through the muscle. Okay, similarly, 2 or more stitches are passed so as to give a good biomechanically stable repair. We extract one limb each from the past sutures. We pass them through something called as a knotless anchor, and basically we pull the muscle and fix it to the bone. So this is how actually, and this is an animation, but this is how actually a rotator cuff muscle is repaired. Okay, so I hope, everyone understands the philosophy behind repairing a rotator cuff muscle. It is basically refixing the torn muscle back to the bone. Okay. Okay, so this is how actually a muscle is repaired. Okay, all right. So there are different ways of doing it. Sometimes we do it with something called as an all suture anchor, where there is no metal, but there is just pure all suture material in it. Okay, and this is how it looks inside while operating. So here, if you see, this is the subacromial spur. So you can see what I'm using is I'm using a radio frequency wand, and we are trying to remove the spur. So this spur is what is hitting the tendon underneath. So this overlying spur is basically causing a lot of impingement. So what we do is we use a burr. This is the burr, and we try and shave off the undersurface of the acromion so that we can create space. Now, if you can see, this is the image after conducting the shaving. Now, here is what you can see. This is the same U-shaped tear in the supraspinatus, which you have seen in the animation. This is what it actually looks like. This inside is the long head of biceps, and this is the U-shaped tear, which is inside the shoulder. Here, as you can see, this is a peak anchor being used. It is inserted into the humeral head. There are different stitching techniques. So what we have done is basically we have used a different stitching techniques for stitching it back. These are the different stitches which are inserted into the muscle. They are inserted into the bone and they are passed through the muscle. Okay, and then what we do is we pass something called as a sutures or sliding knots. So these are specific for the shoulder. So there are different methods of putting a sliding knot, but what a sliding knot does is it basically pulls the muscle and then you lock it. So this is an image of the repaired rotator cuff muscle, where you can see it has been brought back to the bone. The inside of the joint, which you could earlier see, is now completely gone. So this is a completely repaired rotator cuff muscle. So what is the principle? The principle is to restore the flexibility without actually putting a strain on the healing. So very important thing is to understand the surgical procedure, understand which muscles have been involved. The rate of healing is important so that we don't damage the rotator cuff before it actually heals. And we have to make sure that we have to protect the repair before we give them a completely mobile shoulder. So we have to protect the repair as well as conduct physiotherapy. So we have to maintain a good balance. So very important thing I always try and tell my physiotherapist is we have to define what is normal mobility, always compared with the contralateral arm of the patient. And then if the patient has 160 or 170 on the left side, the right side should be the same. So we shouldn't accept anything less than that, but we shouldn't press the patient to achieve something more than that, because that is what was always normal for the patient. So for a patient who has undergone a rotator cuff tear, always remember the healing time is 12 weeks. At the same time, if the muscle is healing in 12 weeks, the capsule also is getting stiffer in 12 weeks. So we have to also make sure that mobilization happens at the same time of healing. We should not wait for the muscle to heal before we start mobilization. Mobilization and healing have to go hand in hand. Otherwise, we end up with a stiff shoulder where the capsule has healed much before and the patient has ended up getting a very stiff shoulder. So make sure that you advise exercises for the patient, following up with you maybe once a day, but doing exercise at regular intervals throughout the day. So what I do is I always ask the physiotherapist to first do a pendulum exercise, some elbow ROM. In the phase 2, always do passive supine forward flexion so that the stiffness is taken care of. 3 is rotation, and the last is strengthening. So strengthening normally begins 2.5 to 3 months after surgery, not before that. Before that, the patient should achieve full range of movement passive, nothing active. Okay, so this is, I showed yesterday, this is what basically a passive supine forward flexion looks like. This is what my patients do for the first 6 weeks. From 6 weeks to 10 weeks, the patient do rotation. This is rotation exercises. And after they have achieved that, then they do some sort of strengthening exercises. Okay, so this is something like a slap tear, but I won't go into this topic right now. And Bankart tear. Okay, so this is what a normal patient should be like. 4 months after undergoing a surgery for massive rotator cuff tear, should achieve active forward elevation, full external rotation, and full internal rotation. Okay, so this should be our target. So is there any question? Because I've taken a lot of time. So is there anything else which people want to ask?
So there was a question.
Yes.
Should we expect any acquired anatomical changes in shoulders of athletes like badminton, tennis, and basketball players, and who have been playing since their childhood? What are the things that we should consider during the assessment?
Yeah. So what we should basically, always check for an athlete is for multi-directional instability. So always remember a patient who has been maybe not mainly for strengthening sports, but some patients who have been doing a lot of stretching exercises or has been active in gymnastics or some sort of stretching projects. If they have some sort of hyperelasticity in the joints, always compared with the contralateral arm, remember that the patient is mobile because they have been doing this sports since childhood, and then modify your exercises accordingly. So a lot of multi-directional instability patients have some sort of a weakness or abnormal directions, and then they lead to intermittent pain in the shoulder, for which we have to ask them to do continuous strengthening exercises or balancing exercises. And you guys are better at it. So that is one thing which we should remember. Plus a lot of single hand players, like, badminton is a sport which is played only with one arm. So maybe one arm is more mobile than the other. Maybe one arm is stronger than the other. So always remember, if patients who have badminton or tennis have one arm much more powerful as compared to the other, which may be normal for them.
Okay.
Anything else?
Nice. Now I think, so what I would like to ask you, as a shoulder surgeon, definitely every condition, every surgery, every injury has a very different and very specific rehabilitation. When I ask you this question, is there any general guideline which you can, give us to just go through it and read it once? When a patient, anyone who comes up and presents with a shoulder injury, what are the general guidelines or thumb rules which have to be, kept in mind?
Okay, so always remember that, like if we are talking about post-operative rehab, so the most important thing for every physiotherapist to remember for a post-operative rehab is the patient should never develop a stiff shoulder post-surgery. Whatever the pathology may be before the patient has undergone the surgery, rehabilitation should be aggressive enough to take care of the repair, but also to achieve a non-stiff or a completely mobile shoulder. So always remember, stiffness is a very, very bad complication which can happen after surgery, which will spoil the name for the surgeon, for the physiotherapist, and for shoulder surgeries as a whole. Okay, so I always ask the patient to follow up with me regularly. They come to me every week, maybe even 3 days, every 3 days, and so that they just show me that whatever exercises they are doing with their physiotherapist is giving them results, is making them sure that they are not ended up getting a frozen shoulder. So I am very scared about my patients getting a stiff shoulder after surgery, and I'm very, very specific about patient doing their exercises religiously. So in lockdown also, I have operated, I usually operated a lot of patients before my elective surgeries got postponed because of the lockdown. So even those patients who have been operated before lockdown, every 3 or 4 days, they are doing a video consultation with me, sending their videos through WhatsApp or showing what kind of exercises they are doing at their homes, but making sure that they are not getting lost to follow. So I again, always ask the physiotherapist to talk to their patient before they take up a project. I call the patient a project because this is what you're putting your heart and soul in while giving them the complete result. That ask the patient to be sincere in follow-up. Shoulder surgeries are not like knee surgeries. Knee surgeries you can get away with, but shoulder surgery you can never get away with. So always remember that whenever you commit to a patient, the patient should be equally committed to you in their follow-up. Okay, so have this clear-cut discussion before you take up a project for a patient, up to giving him the full result, that they follow up with you when they start their physiotherapy.
Okay. So what are the common shoulder pathologies in pediatric patients, and what are the do's and don'ts that we should particularly follow in such patients of growing age?
So usually shoulder pathology in pediatric is not very commonly seen. As I said earlier, it's a growing age. A lot of boys as well have lax ligaments. So usually what happens is subluxations. So more than dislocations, what you hear are subluxations. So the patient do have intermittent popping out of the joint, but it is self-reducing and painless. Sometimes it leads to pain, but remember, subluxation does not have to be immediately treated. They can be given good scapular stabilization exercises, good rotator cuff balancing exercises, and then do well. Very rarely will you encounter a patient with a stiff shoulder in a pediatric population. So usually stiffness never happens in pediatric population. And then if it does, you always investigate the patient for some kind of a nasty problem inside the shoulder. Okay. Anything else? So I'll just share my this number, my online consultation number. So I think you can do the
Sir, I have a question.
Yeah.
Sir, in paralysis cases, one-sided hemiplegic cases, there is a lot of time we have seen a subluxation of the shoulder, and later they develop a frozen shoulder because of inactivity of the muscle. We can say a paralysis. So, what do you think? Stabilizing a shoulder is important that time, or our role is important that time?
So, any time patient presents me with some hemiplegia with weakness in the shoulder, I am not the boss, the physiotherapist is the boss. Hello?
Yes, sir. I've just put her on mute.
So basically, any patient with hemiplegia, I always refer them to a physiotherapist. Not much shoulder surgeons can do. We never touch a patient with any sort of hemiplegia, which has led to, some nerve problem, which is directly CNS related. So, really not much of surgical treatment or any sort of surgical maneuver can help. So, no local therapy in the shoulder works. It's always a neural complaint. We always try and take care of keeping the shoulder as mobile as possible. Always remember, a patient with hemiplegia will have osteoporosis. So before you think of doing any kind of manipulation or forcibly moving their shoulder, you will end up with getting a sort of a maybe stress-related fracture. So be very careful by performing aggressive exercises on a patient who has hemiplegia, because sometimes their shoulder capsules are more stronger than the humeral bone. So sometimes while doing that, you might actually fracture the humeral bone before you can release the capsule. So, always keep that in mind for hemiplegics.
Okay. Sir, what is a surgeon's perspective when we are approaching a frozen shoulder, and exactly, what are the things involved in that? So as far as exercise is concerned, exercise protocol is concerned.
Yeah. So number one, whenever patient, I discussed the same thing in my last lecture. So frozen shoulder or stiff shoulder, the number one thing which a physio or a surgeon, I'll consider them to be a team. So what we have to basically do is find out the cause of the frozen shoulder. Always remember, the treatment of a frozen shoulder only begins after you have zeroed down the cause. If the patient has a frozen shoulder, which is a primary, go ahead with aggressive physiotherapy. If it is secondary to a pathology, first take care of the pathology. So whenever you are asking a patient to undergo physiotherapy, make sure that you have diagnosed the patient correctly. Okay, that is number one. Number two, always, at least in I'm not an expert in physiotherapy, but whenever I conduct some kind of an exercise program for the patient, I try and do it supine, for the reason that patients don't cheat. They always don't, go into hyperlordosis, and the movement actually happens at the shoulder joint. So even my rotation exercises are conducted supine. So what I do is I ask the same exercises which you're doing standing up, I ask the patient to do it supine, for the only reason that patients, try and not lift their body or move their body as much as they do when they're standing. So if you are conducting some kind of a passive forward flexion or external rotation, only internal rotation is one exercise which probably I do it standing up, but remaining exercises I try and ask the patient to be supine.
Okay.
Okay.
Yeah.
Next, one more important thing which I'd like to tell all physiotherapists is your patients are the most lazy or the most non-compliant when it comes to home exercises. They only do physiotherapy when they come to you, and whenever they go back to their homes, they absolutely forget about physiotherapy. So that is one thing you have to tell your patient, that I am just doing your exercises. I'm doing the exercises for you maybe once a day, but you have to do it thrice a day when you go back. So make sure that the patient does physiotherapy at regular intervals, every 4 hourly or every 6 hourly. So that is very important. They just don't do it once a day, because the rest of the time, then they are absolutely just keeping their arm in one position and ending up in a bad shoulder.
Okay. Sir, if a patient comes with cervical rib and comes down with a shoulder pathology, are there any particular precautions to be taken?
Yeah, cervical rib will present with its own vascular complaints, with its own neural complaints, and shoulder may not be may not be one of the more important reasons for her pathology. Cervical rib should be first taken care of, and if the patient has cervical rib but has shoulder pathology, like as in it actually has some sort of a partial tear, a bursitis, a long head of isotendinitis, a full thickness tear, slab tear, whatever, then take care of the pathology. Forget about the cervical rib, because the cervical rib may not be the cause of the problems. So, finding out where the cause lies is how you actually go ahead and treat the patient.
Okay. So anyone else wants to ask any questions? I think we'll take questions from everyone now. If you want, you can ask the questions directly, please.
Okay, so I hope, it was an interactive enough session, and I was happy that I could actually get to hear a lot of questions from the physiotherapist end. And these are the actual, patients which we see in our consulting, because talking theoretically and talking practically are two different things. And what we do is we work, all of us are basically more of practical people, I guess. At least I am. So don't ask me too many theoretical questions and percentages, but I'll be able to tell you my own experiences. That's how I work. So, happy to have a good interactive session with all. And if there is anything, I think in the chat section, there has been a number shared. Yeah. So this is our shoulder clinic number. Feel free to ask me or post any doubt you have, and I'll be happy to answer them 24/7.
Sure, sir. Thank you. And I would really like to thank you on behalf of, hello.
Yeah, and thank you, Prerak, and thank you, Ask Physios, for conducting such a wonderful webinar, where I had a privilege of having this discussion with so many physiotherapists at one go. So thank you, everyone. Thank you for attending the session with me.
Thank you, sir. And I would like to thank you on behalf of all of us physios that you could spare so much of your time and expertise. And I'm sure definitely it will help us in the longer run. And you have, very rightfully said, कि अगर किसी को भी कोई doubts है, they can always contact you. So I think it was, I would be very grateful for your time and for your expertise. Thank you, sir. Thank you.
Sure. So, sure. Thank you so much.
Please take care. Sure.